So looking at our laundry list, pretty much across the board, we've got theorist and math questions. So with those theorists, we did that concept map last week. That's going to be your best bet for studying and memorizing them. Coming up with that keyword for each theorist that helps you figure out what that main idea is. A lot of students have said that rewriting that concept map in their own handwriting with different colored pencils is extremely helpful for studying and memorizing those theorists. You also have that theorist only Kahoots that gives you examples of each of the different theories, the breakdown, some patient examples there, matching. So those are available to you as well. And then I will show you in the exam one review announcement at the end of class today, Professor Bogart's links for math videos for math help. And then you guys have worksheets that will come out with each exam that will help you practice that weight-based dosing. So those are your two best resources for that math practice. So this week we are going to be shifting gears. We're moving away from those age groups and those specific theories, and we're going to apply them to the hospital setting now. So this week and next week, we're looking at how hospitalization impacts our pediatric patients. So things that are different for them from taking care of adults. Also looking at kind of taking what we've learned about the different age groups and how it affects them in the hospital. So let's dive in there. So our first question here, what situations are going to require informed consent and are not going to be covered in that general hospital consent? So we've got that general hospital consent that kind of gives us that blanket ability to treat you. And then we have that extra level of informed consent. So which of those is going to be that extra level of informed consent? Okay. So for our general hospital consent, that's going to cover all of our lab draws, our basic procedures, things that you expect to do to a majority of your patients, gives us permission to treat you. That extra informed consent is saved for those procedures that not everybody across the board is going to get, or they have an added layer of risk to them. So we know that blood transfusions have some extra risk associated with them. They aren't necessary or the only option for treatment. We do have other options that we can use if patients refuse to receive blood. But because there is that extra risk factor, we require that informed consent. Same thing with invasive procedures. So those are going to be surgeries or a little bit more advanced procedures. Our peripheral IVs are going to be included in that general hospital consent, and that's what we get on admission. If we come in with a life-threatening emergency, we are not going to delay your care by making you sign paperwork. We want to make sure that we get you stabilized and safe before we go around to doing any additional paperwork. So we will treat you without any consent, honestly, until we get you stabilized. So thinking about our pediatric patients, what are some extra safety precautions that we have to take with them that we might not have to take with adults? You guys can type them in or shout them out, either one.
Med errors.
Mm-hmm. Yep, our medications are dosed differently. We have to do that weight-based dosing. They have extra hospital bracelets. Yes, that's true. They have their patient bracelet, but then they have bracelets to match them to their parents. So we make sure that we're discharging them or providing information to the correct guardian. What else? Yep, we have more supervision with them. We tend to keep them close to the nurse's station where we can keep eyes on them. Their rails on their beds. Yep, so we've got those crib side rails and we keep them up all the time. We also have that extra plastic covering that we can do over the top of the crib to keep them from climbing over that side rail. That bubble top we can use. Um, yep, checking for safe sleep, making sure there's nothing extra in their bed. What about when we're transporting patients? What's different with the transport? Oh, code Adams. Yep. If we have a missing child, we do more frequent vital signs, looking for choking hazards. Yep. Yeah, our pediatric patients may or may not be able to do those activities of daily living by themselves. So we'll have to be present when their meal trays come around so that we can cut up their food if needed. They might need help with feeding. If we have to take them for a procedure, how do we move them to that procedure? If it's outside of their room, what options do we have?
Depending on how old the kid is, it could be wheelchair, wagon,
Mm-hmm. Yep. So making sure we're
bed.
using, yeah, we can use their bed, their crib. We can use a wheelchair, making sure it's a pediatric wheelchair so they're not sliding down the back or in underneath those arm rests. Wagons are frequently used to transport patients in the pediatric setting. It's a lot more fun than having to ride in your bed or a wheelchair. What else do we have to keep in mind? Same thing we would do at home. What do we have to monitor for safety? Do we just leave them in their room by themselves with nothing to do? Yep, we're gonna childproof the hospital room just like we would at home. So making sure those cords and those outlets are covered. Uh, Making sure we're providing safe activities. Yep. So we're looking for those developmentally friendly activities that are going to help to promote that development for them. Also, making sure our toys are safe. So just like we would check toys at home, we're going to check them in the hospital setting. We talked about equipment. The other thing with child proofing is where the bed is located in the room. We don't want to have it right up against the wall where like our code blue button is. Those are pretty colors to catch our attention. So you can guarantee it's going to catch your child's attention. We don't want them to be able to push those buttons because you know they're going to try. Same thing with our IV pumps. If you have an extra curious child that loves buttons, you might have to lock them out of your IV pump so that they're not pushing buttons and changing your rates on you. So those are some more things that we have to think about with our pediatric patients that we don't necessarily worry about with adults. So now we're going to put it into practice. We are going to take a look at this hospital room. Tell me some of the things that you see that are wrong or potential safety issues in that photo. You can either click on the photo or you can just shout them out. Tell me what you see. We've got the bed rail down, our bed's elevated in high position. Nurse has our back to our patient. Nobody's really paying attention to our patient in the bed, and it looks like he's about ready to climb out. We got sister standing right behind a door. So if anybody,
Even the mom's not paying attention.
yeah, yep, mom's not paying attention. She's over there reading. Um, no clue what sister's up to. What else do we see that's potential issues here? So in this case, we have male and female siblings, but what happens if we had two male siblings that were similar in age? What could happen?
Rivalry?
We could have some sibling rivalry. Yeah, you can see a lot of behavior issues because one child is getting more attention than the other. Like medication administration or procedures, if we have multiple children in the room and we're not paying close attention. Or if we have twins. What happens if we aren't identifying our patients appropriately?
We could give the wrong person the.
Yeah. Yep. We can mix up siblings, twins, especially. Just because your patient is sitting in your bed doesn't mean that's actually your patient.
Yep.
We also like to move patients around a lot, especially when they leave for a procedure. It's a great time to switch their room while they're out of it. So make sure that you are properly identifying your patient using their ID bracelet. What would happen if our patient was on oxygen or on continuous IV fluids? What could be a potential hazard there?
Pulling their IV out.
Yep. What else can happen on that IV tubing or oxygen tubing?
Choking hazard.
They could if they're rolling around in their bed and they get it wrapped around their head. What's more likely to happen if we're trying to jump out of bed and we've got tubing everywhere?
They could fall.
Yep. It's a tripping hazard. We'll trip and fall. So making sure that we're keeping that tubing up off the floor, making sure they know not to get out of bed by themselves. They need mom or dad with them or the nurse. What else do we have to keep in mind with oxygen tanks? Can we just have them wherever we want to? How do we have to store those tanks?
Secure in the holder.
Yep.
So
we've got to,
not on the floor.
yep. We've got to use that holder. It has to be secured to something else. So does anybody know what happens if an oxygen tank falls just right and it lands on that valve?
It can explode.
Yep. It explodes or it will shoot across the room like a missile. So it will rocket itself across the room and it will take out anybody in its path. It will go through the wall, whole 9 yards. So definitely something we don't want to have happen because that's going to cause a lot of damage. So making sure those tanks are secured to something else. So typically we either store them upright attached to the IV pole or we'll store them horizontal underneath the bed. And it's got a little holder under the bed that it fits into. The other thing that I see in this picture is this medication cart up in the front corner. We don't know if it's a medication cart or if it's a supply cart. We also don't know that it's necessarily locked. So if that cart's not locked, you can guarantee maybe little sister's going to be going through there trying to figure out what's in the drawers. Curiosity is going to get the best of these pediatric patients. So making sure all of our supplies are locked and out of reach so that they're not getting into them. Anything else we see in here that could potentially be unsafe? I think we got most of them. So now I'm going to ask you to share a little bit here. We're going to think about hospital experiences. So these can either be something that's happened to you personally, or these can be hypothetical situations. You don't have to share a lot of detail if you're not comfortable with that. But think about a time that you had a positive hospital experience. What about that experience made it a really good encounter? And it can be any type of medical experience.
When I had one of my babies, there was a nurse. She was there with me the whole entire time, and she like did everything that I wanted the whole time. I don't know. She was very supportive and very kind.
Yeah, you can definitely tell when people care about you and they go that extra mile for you. They take the time to listen. They anticipate your needs. So they make sure that your needs are provided for. You can tell when somebody cares about you or if you are just a task that they have to check off. So your nurse's attitude makes a big difference. What else? Anybody else have any positive experiences?
Yeah, I took my one of my twin sons into the children's hospital. He had a swollen eye, and it looked like it was bruising. We thought his older brother was the one who hit him. So we actually had child services in the room. There was a cop outside. Come to find out, it was a serious sinus infection that was eating away at his nostril cartilage and ate away at his tear duct. So it was a great experience because they actually listened to us before they started with any other kind of senseless proceedings.
Yeah, that's awesome because that could have totally gone the other way very easily. So actually listening to parents, parents are your lifeline. They are the best resource that you have when it comes to pediatric patients. They know their kids better than anybody. So definitely listen to them when they tell you something is wrong or not wrong with their kid. They know what normal is because they spend the most amount of time with them. Anybody else have positive experiences? Let's move on to probably what comes to mind a little bit easier are those negative experiences. So think about a time that you had a negative experience with healthcare, and what was different about that experience that changed your perception?
Well, I had surgery, and the nurse didn't really look good at my allergies, so she given me medication which that I was allergic to.
Oh, that's a big one.
But when she caught it, I mean, I could hear her outside calling pharmacy, and they were telling her what to look out for, and yeah.
Okay.
So, I mean, it was a little upsetting, but when she investigated and tried to make sure and come back in and did my vitals and everything.
Yeah. Yep. At least she took care of it and didn't just try to hide it or cover it up.
Yeah.
But definitely not something you want to have happen.
Um, it wasn't specifically my experience, but I know of someone that kind of had the same experience, but it wasn't like the wrong medication. They gave her too much of a medication, so it caused her to have like a severe side effect.
Mm-hmm.
And basically, she just like had to call a lawyer and stuff like that.
Oh, wow. So maybe rushing, not taking our time, making sure that we're doing all of our research ahead of time before we go see our patients, before we give our medications. What else can change that hospital experience? What can
Or
turn that into a negative?
even like the opposite of the good, like them not listening to your feelings and trying to understand what you're going through.
Mm-hmm. Yeah. It's very easy for us to just look at a patient and say, this is what the textbook says, and this is what I'm going to do, and you're a task on my list. And forget that we have our own feelings, our emotions, our own experience that goes along with being in the hospital. What happens if I walk in and I just stand in the doorway with my arms crossed and I'm constantly looking at my watch? What does that tell you about me?
That you're in a rush.
You're ready to go. You're not physically, there with the patient. Attentionally, you're just there and trying to get over with.
Yeah. I only have a limited amount of time for you. You're not important to me. I have something else that's more important that's calling my attention that I'm waiting for. Uh, our body language tells a lot. If I am standing with my arms crossed, I look closed off. It looks like I don't really want to have this conversation. Whereas if I walk into the room, go to like the other side of your bed and sit down in a chair and start to ask, how's your day? If I start that way, what does that portray?
That you're actually interested,
Mm-hmm.
that
I'm
you care.
interested. I'm here for the long haul. I care about what you're about to tell me. That gives you the opportunity to feel like you can ask questions, to feel like you can take your time. So our body language tells a lot about our experience. So thinking about those positive and negative experiences, how do we make sure that we guarantee that positive experience for our pediatric patients? What are some things that we can do?
You get down on their level for sure.
Yeah.
And you want to explain things in the way that they'll understand it.
Mm-hmm. I've even caught myself, if I'm taking care of a pediatric patient, talking to their parents and not talking to them. That's huge. If you make sure that you're including them, take the time. Yes, you can explain it to their parents in adult language, but then make sure you take the extra time to go through and explain it to them again in a way that they understand. It is their body. We are doing things to them, so they have every right to know what we are going to be doing to them as well.
Because you'd rather explain it to them than them just go in there and it be a surprise.
Mm-hmm. Yep. With our preschoolers that are very curious about things and have a lot of fear, what can we do to help take away some of that fear before we're doing a procedure or something new?
Show it to like mom or dad.
Yeah, we can show it to mom or dad. We can do it on a doll or a teddy bear, stuffed animal. Let them play with the equipment if possible. That's really, really helpful for them. If they can get their hands on it and they can use their senses to work through what it is and how it's going to work on them, then it takes some of that fear of the unknown out. So that goes a really long way with our preschoolers. Anything else that we can do to improve that hospital experience?
My kids always hate it, like whenever they got tubes in their ears, so they're very sensitive when like the doctor goes in and looks in their ears, they
Mhm.
freak out. And she's always like, well, I'm just gonna go see if there's dinosaurs in there. You know, like she makes it like an imaginative moment for them. They'll be like, oh, okay, like,
Yeah.
oh, like that's like I thought that was really cool how she does that.
That's great. If you can turn anything into a game, you're going to be more likely to get their cooperation. Same thing with offering choices, letting them choose what color band-aid they get or what color popsicle. That's going to go a long way. When we put them in the hospital, we tell them what they can wear, where they can go, what toys they can play with, what they can eat. We take away a lot of control. So anytime we can give some of that back, you're going to get a lot better reaction from that child. Other things we can do for that positive experience? I like the dinosaurs in the ear. That's a good trick. I'd want to know.
She does it to their belly too. Like she's listening to see if there's dinosaurs in there.
Yeah, that's great. Okay. So as we're thinking about those assessment skills that we're doing with our pediatric patients, what's different in a pediatric assessment, either in what we find or how we do it, than adults? What are some things that we expect to find in our pediatric patients that we may or may not with adults?
Higher rates.
Yep, our vital signs are different.
Their body might not function like fully as an adult would.
Yep, we've got immature organs, so we can't necessarily anticipate how they're going to react to certain things. Growth and development, yes. We track and measure them a lot more than we do with adults. We're looking at those milestones and their skill acquisition. We don't necessarily do that with adults. We expect you to be able to do what you can. They are more fragile. Their understanding of procedures is different. So our communication with them is going to be different. What else? Can we just come in and start assessing them?
No, you want to engage them to what you're doing.
Yeah, you have to build that trust.
Yes, absolutely. We've got to build that trust. They've got to get to know us before we just come in and start trying to listen to them. They're going to scream at us if we do that.
Because you got to think these kids, they've been going to the doctor over and over. Well, most kids will be going to the doctor frequently, so they already know what you're about to do.
Yeah, yep. All they know is you are likely going to do something that hurts. So they don't want you anywhere near them. So working through that, letting them listen to themselves too. That's a great way to get them to cooperate with you. Allergies, yeah. In pediatric patients, we might not know that they have an allergy to something yet. So when we give them immunizations or when we're trying new things with them, then we do have to monitor them a little bit longer than we would an adult just to look for those allergies. That's a great one. Talked about differences in vitals, body systems aren't fully developed. Where is the best place to assess an infant?
In the crib, like if you're talking about like a little baby, like a newborn, it would be in the heating, I forget what it's called, the little incubator thing.
There's one other place that is going to keep them more comfortable than their bed.
With their parents.
Yes. Yep. So if you are trying to assess an infant, I highly recommend keeping them in their parents' arms as much as possible. They are going to be with that person that they trust. So they're going to be a lot more relaxed and calm. Only expose one little area that you're looking at the time. Try and keep them swaddled as much as possible. Those boundaries make them feel safe. Do as much as you can with the parents before you put them in the crib. Maybe when you go to change the diaper, then you can do the assessment pieces that you couldn't get to when they were in parents' arms. But keeping them with that safe, protective person keeps that trust going, helps them to build that trust with you, in addition to that parent as well. So they're going to be a lot more receptive to you if they have that person, that security person there for them. Other things that we can think about with pediatric assessments. I think you guys got the majority of them. So let's go ahead and let's take a peek at Eliza. We are going to look at her, and that's going to help us to also look at some of these experience things and assessment skills too. So I'm going to pull up Miss Eliza here. So as we look at Eliza, we're going to listen to her report, and then we're just going to comb through her medical record. So as you're listening to reports, think about what the important things were that they told us, crucial to her care. And then also think about what they might have left out when they gave their handoff report. So let's take a listen to Miss Eliza. Let me know if you guys can't hear this.
This is the PACU nurse giving you a transfer report for a client we are bringing to your unit shortly. We should be there by 1920. Eliza Simmons is a 9-year-old who fell this morning approximately 14 feet from a treehouse in her backyard.
It's kind of quiet, isn't it? Let's get this turned up a little bit here. Let's try using the speakers and see if that will work. Okay, let's try again.
This is the PACU nurse giving you a transfer report for a client we are bringing to your unit shortly. We should be there by 1920. Eliza Simmons is a 9-year-old who fell this morning approximately 14 feet from a treehouse in her backyard. Eliza has autism spectrum disorder. The total body scan revealed no fractures, except the right femur was a complete non-displaced and closed fracture. She has many scrapes and bruises, but no internal injuries. She did not lose consciousness, and she was cleared of C-spine. Neurologically, she is stable. It is believed she took all the weight of the fall on her right leg. She is here with her 2 dads, and they will be coming to the floor with her. The surgery included pinning of the right femur. Her estimated blood loss was 250 milliliters, and she received 1 unit of PRBC's estimated blood replacement, 200 milliliters. She has a long leg cast to the right leg from her toes to her groin that is still wet. Neurovascular status to her right foot is intact. She has an IV in her left wrist infusing D5, 45 NS at 60 milliliters per hour. She has not voided since surgery. She is sleepy and just received a dose of morphine in the PACU. Breath sounds are really shallow. We keep encouraging her to take deep breaths, but so far she's refusing. We use the FACES scale for pain, and it worked well since she is still so sleepy. For any other information, please check the EHR. Thanks so much. Call with questions.
Okay. So what were some of those important things that they told us when it came to Eliza?
You want to know important things?
Yes. Yep.
She has autism.
Yes. What else?
She has shallow breaths.
Shallow breaths. Yep.
She has avoided since surgery.
No voiding. Yep.
She did not lose consciousness.
Very important with that fall that we didn't lose consciousness.
I feel like most of this is really important.
Yeah, yep, a lot of it is important. What they did surgically, the blood loss and the replacement. What are things that they might have left out on her report? Things that you are still curious about?
Where were the parents at this time?
Mm-hmm.
Why was she up in a tree house alone?
Yeah.
Mm,
Situation details.
yeah.
They didn't tell us if they gave any pain meds.
All they told us is she just received a dose of morphine. They didn't tell us anything about
Oh,
the
okay.
morphine dose. They didn't tell us how effective it was. That would have been good to know.
Is she on other like medications?
Mhm. Yep. We don't
They
know.
said that she's super groggy and she's very sleepy, that she can't even sit there and talk to them.
Yep. Still very sleepy. Anything else they might have neglected to tell us?
Um, her oxygen saturation?
They didn't give us any vital signs.
No.
We don't know anything about her vital signs.
What about allergies? I didn't see that.
We didn't talk about allergies yet. What about her cast? Might we want to know?
If it's waterproof?
When was the last circulation check?
Yep, circulation check, whether or not it's a waterproof cast, that's going to help us with discharge. With that cast being wet still, what do we want to know?
If it's fiberglass or plaster.
Yeah, we want to know when that cast is going to be dry, when we can be a little bit more liberal with our activities and making sure that we're not going to put pressure points if we accidentally touch it or bump it. Those would be good things to know as
I
well.
was told it takes more than 24 hours to let the cast dry.
Yeah. Yep. So
That
those casts take a long time to fully set and harden, which is why we don't let them up and around right after that cast is placed. We don't want them to be weight bearing.
Also, she has pins in her right femur, so they didn't say anything about the weights, how much weights, or anything else like that.
Yep. So I think those are going to be internal pins rather than the traction pins. So I think they went through and put a plate in there and then screwed in to keep that femur in alignment. But yes, if we had to do traction or anything, that would be good to know as well. Okay, let's dig into her medical record and see what we can find here. And it's dear sweet time. There we go. Okay. So if you are following along on your own device, go ahead and jump to question number 3. So skip answering the questions, just jump to question number 3 so that we can look at her entire medical record at once. So let me zoom in a little bit so that we can read this better. Nope. Okay. So looking at that admission nursing note, so when she made it to the floor from the PACU, we learned that she's had no surgeries or significant medical issues. She does have autism spectrum disorder. She functions at a high level and can read and write. She prefers routine and order, struggles with changes in her normal day, and one parent is going to be at the bedside at all times. Also, we find out that she has several allergies. So if we look up at her kind of header there, we see she's allergic to latex, peanuts, adhesive, and has environmental allergies. So those would have been good to have in handoff. What else do we learn about Eliza that's going to change how we interact with her? What do we learn about her in that first note from 1935?
That
she
she's
has
autistic.
autism.
Yep, we know she's autistic. What does she like? What works well for her and what doesn't work well for her?
Routine and order.
Yep, she prefers that routine and order. She doesn't like change. So how do we find out what that normal routine is?
Ask her.
Who else can help us with what normal is for her?
Her
Her
parents.
parent.
Yep, she's got parents at her bedside at all times. So we can always ask them. We can ask her. We can try and implement a lot of that normal everyday routine or certain ways she likes things done as much as possible in the hospital to improve that experience for her. Give her that sense of normal. So looking at that initial assessment here, we've got our right foot and our left foot without changes. We don't have any swelling. Our toes are nice and warm and pink. We're able to move them. We have strong pulses and good cap refill. We've got positive sensation, and our pain is a 2 out of 10 on our FACES scale. Looking at our LDAs here, we've got that long leg cast to the right leg, extending from her toes to her groin, still wet to the touch. And we see red drainage noted on the cast site and marked with a felt marker. So how do we feel about those initial assessments? We stable, unstable, anything that's a little offsetting? Got your spidey senses tingling?
One thing I'm looking at is it says it goes from her toes to her groin. How far up the groin does it go? Is it impeding anything? Is it, creating a pressure sore?
Yeah, that would definitely be something to look out for. How do we feel about that neurovascular assessment? Is it a good assessment or are there things that are questionable in there? Expected or unexpected?
Expected.
Yeah, that's a normal assessment. We don't have any issues there with that neurovascular assessment. Anything with that cast that might make you a little nervous?
The drainage.
Yeah, we have red drainage. What could that potentially be?
Hemorrhage.
Yeah, we could potentially have bleeding here. So lo and behold, 20 minutes later, that red drainage that we had moved outside of the marked spot on the cast. So it's expanding and it's expanding pretty rapidly. So we're going to go ahead and call the healthcare provider and ask them to come assess the cast and the drainage. So they ask us to give half a dose of morphine because they're going to cut a window into the cast so that we can look at that incision. And we find out that that incision has been actively bleeding, and that's what was causing our red drainage. So our physician resutures that incision, puts a liquid plastic dressing over it so that we can continue to monitor that incision site. As to be expected, Eliza becomes agitated during the procedure. She calms with soft music and repositioning and room darkening. And then just updating kind of her overall condition here. She's now taking sips of diluted apple juice and water. She has voided using a fracture bedpan, still has those shallow and rapid breaths, and is refusing her incentive spirometer. So how do we feel about her overall condition here? Is she improving? Is she getting worse?
She's not really improving if she's not gonna with her breath sounds, and she's not gonna try to use that incentive spirometer so we can get her oxygen levels up.
Yeah. What are some things that we can do? It's very common for our pediatric patients to refuse their incentive spirometer. It's weird looking, it's confusing, um, it looks scary. So they don't like to do them very often. What are some fun activities that we can do instead of that incentive spirometer?
Blowing up balloons.
Mm-hmm. Yep. For her, we would have to be careful because of that latex allergy.
Make a game out of it.
Mm-hmm.
The Three Little Pigs.
Yeah. Yep. Three Little Pigs is a good one. Blow bubbles. Yep. Yeah. Have her blow something across that bedside table, whether it be a cotton ball or maybe you can find a little ping pong ball or something from the game room that she can blow across the table. Have her pretend to blow out birthday candles, or blow a pinwheel. Any activity that helps her to take those deep breaths. If we make it a game, we do something that's fun, she's still going to take those deep breaths. She's going to expand her lungs for us, but she's likely to be more compliant than if we just say, no, you have to do this incentive spirometer. What else do we learn about her that's going to help us with future procedures?
Well, explanation.
Mm-hmm. Yep. Explaining things to her. What can we do proactively to improve her experience if we have to do another procedure on her?
Give her a time frame.
Possibly. Yeah. She got agitated this time. What helped her not be agitated?
Calm music.
Yeah. Soft music, that repositioning and room darkening. We know those are effective interventions for her. So if we have to do another procedure, we can go ahead and dim the lights, maybe just use a spotlight, so that we can keep the rest of the room nice and dark. We can turn on soft music, make sure that she's comfortable before we get started. All of those are going to help improve that experience the next time that we have to do something with her. Okay, so now we have our next complication. So our first complication was that bleeding at our incision site. So we are going to give an S-bar as our handoff, talking about this situation that happened. So first, we're going to start off with who are we talking about? What are we talking about? So our situation is we have a 9-year-old that had an open reduction and fixation of a right femoral fracture last evening. Then we're going to kind of give that history, what's been going on, our background. Our toes were swollen last night, but the swelling resolved by this morning, at which time her neurovascular assessment was normal. Now we have increased swelling. So that's why we're calling. Then we're going to go into what we're seeing. So our assessment, our toes are cool and pale. She cries when asked to wiggle her toes, and she has a weak dorsalis pedal pulse. And then we're going to go into our recommendations. So what have we done so far, and what do we want to have happen? So far we have elevated that right leg on 2 pillows, and we would like the physician to come and evaluate her within the next hour. What do we think is going on with this change in status?
She could have third spacing.
Mm-hmm. Yep. So we could be developing compartment syndrome here, which is going to be a big red flag for us. Why is compartment syndrome a problem?
It's painful.
It is painful.
Neurovascular.
Yeah. Yep. So we're cutting off circulation here with this compartment syndrome and this swelling. So what might our physician ask us to do? What should we be prepared for when they come up?
Got that cast.
Yep, we're going to be cutting that cast off very likely. So we can go ahead and gather all of those supplies. If we're doing another procedure, what should we probably do if we're going to be taking that cast off to make sure she stays comfortable?
Soft music and dimming the lights.
Yep, doing those environmental modifications. What else? We're going to be manipulating the leg that she just had surgery on.
Pain medication.
Yeah, pain medication. Go ahead and get it on board now so that it starts working when they're coming up to do that cast removal and replacement. So looking at that neurovascular assessment, at that time, we've got that left foot without change, no swelling, but right foot where she had surgery has significant swelling. We have cool and pale toes. Moving them causes pain. She does have a strong femoral pulse, but a weak pedal pulse. So we know that below that cast is where the problem is. Her cap refill has slowed a little bit. She does have sensation, but she has an 8 out of 10 on her pain scale. So definitely going to be getting ready to remove that cast. So making sure we've got all of our ducks in a row there. So unfortunately, that is not Eliza's last complication. She has one more that happens. So later on that day, they noticed significant swelling and redness in her left hand around her IV site, and it's going up her arm. So what is that going to be a sign of? What happened with our IV?
Infiltrated.
Our IV is bad. It is no longer working. So we go ahead and take out that IV. And now we need to decide whether or not we're going to put in a new one or if we're just going to let it be. So now, at this point in time, Eliza is taking oral fluids well. She's able to eat crackers without nausea or vomiting. She has active bowel sounds. She's voiding sufficiently. Her pain is being managed with oral codeine and acetaminophen. And they are working on teaching with parents once they're both at the bedside. So what are our thoughts on restarting that IV? Is it necessary or not?
No.
Nope, we don't need to put it back in. Assuming that she went through all of her post-op antibiotics, there's no reason to restart that IV. With pediatric patients, we only leave them in as long as we need them. So as soon as they have made those steps to be able to maintain their nutrition and their pain management orally, then we can go ahead and leave that IV out. We're not going to re-stick them just because we want one present. Great job, guys. So let's take a peek at Miss Eliza's vital signs. So what do you see there in her vital signs that looks a little questionable?
Her temperature,
We have an elevated temperature.
her O2.
Yep, we're only satting 94% and we are on 1 liter.
Then the 21 shallow breaths.
Yep, we've got our respiratory rate is 21 and they are very shallow. What are some things that could be causing our low oxygen and those shallow respirations?
The pain medicine.
Yep, she's on morphine. Morphine causes respiratory depression or has the potential to cause respiratory depression. What else? What other factors impact our breathing?
If she's sleeping.
Yeah, if she's still really sleepy. They talked about her being groggy afterwards.
Her pain level?
Yes, pain. Pain impacts our ability to breathe. If we hurt, we don't like to take deep breaths, or we tend to hold our breath. Tend to tense up all of our muscles when we hurt. With that shallow respiratory rate and that low-grade fever, what concerns might we have?
Infection.
Possible infection. What's she putting herself at risk for? Developing something.
Pneumonia.
Pneumonia. Yep, we are at high risk for pneumonia here. We've already got some respiratory symptoms that we're seeing here. We're shallow breathing. We're not doing that incentive spirometer. We're post-op. We are high risk for pneumonia here. Let's take a peek at our orders. So when we first come to the floor, we've got our IV fluids that are ordered. We have multiple options for pain management. So we've got IV morphine, we've got oral codeine, we have oral acetaminophen that we can mix with the codeine if we need to. We have our pre-op and post-op antibiotics. We are NPO until we fully wake up, then clears and advancing as tolerated. Bed rest until tomorrow we can get out of bed to a chair, and an incentive spirometer every hour. Physical therapy consult also. So what are some good things that they did with those initial admission orders? What are things that make you happy to see?
The IV with the fluids, pain medication.
Yeah, we have multiple options for pain. So they've done a really good job with those pain management orders. After we have that initial complication and we cut that window into our cast and we re-sutured our incision, we have hourly site assessments for the first 24 hours to make sure we don't have any additional bleeding. We also order a hemoglobin and hematocrit, and we prolong that bed rest a little bit longer. Anything else we would like to see in all of our orders for Miss Eliza?
Vital signs.
Yeah, we would like to see some vital signs. Anything different out of that normal policy? With that risk for infection, what might we want to see?
Antibiotics.
Possible antibiotics. We've got those standard pre-op and post-op antibiotics. What do we do before we jump to treatment?
CBC.
Yeah, we're already drawing a hemoglobin and hematocrit. Let's just expand that a little bit to that full CBC. Same amount of blood, same tube. That way we can see if we have a potential infection brewing. That's going to be our first line for our labs here. So let's see what we did for labs and diagnostics. So we did do that full CBC. What do we see here? What's encouraging?
Her white blood cell count is in the normal range.
Yeah, her white blood cells are normal, so we probably don't need to worry about infection. Likely that was an environmental elevation in her temperature. What is slightly concerning?
Her blood loss.
Yep.
Hematocrit.
Yeah, her hematocrit is low. Her hemoglobin's right on the border. The good thing is her platelets are in normal range, so she should have enough to be able to clot on her own, but that's something that we definitely want to keep an eye on and continue to monitor. We know they replaced her blood loss in surgery, but she might need some additional blood replacement or additional fluid after surgery there. Okay. So last thing is that cast care teaching checklist. So we find out that we have a non-waterproof cast. So we're going to teach care about that, skincare, toileting, bathing, cleanliness, circulation checks, safety measures, range of motion, physical therapy. Weight bearing is deferred for the time being. What additional teaching would we want to do with parents? How do we go about doing that teaching?
Well, signs and symptoms.
Yeah, signs and symptoms to look out for? When do they need to call if they are having concerns? What else are we missing here?
Medication.
Yep. Any medication she's going to be on? When do we want to start this teaching checklist?
Teaching should be started during admission, right?
Yeah. So we want to start this as soon as she gets to the floor. So we can help parents work through, getting her mobile, getting her moved around. They can help with skincare, teaching them those circulation checks as we're doing them. Great way to have an extra set of eyes immediately post-op is teaching them what you're looking for when you do those neurovascular checks. Anything else that we might be missing here? Or things that you want to emphasize with cast care?
Not to stick anything into the cast.
Yes, casts are itchy, and our first reaction is to shove something in that cast so that we can scratch.
Keep it dry.
Yep, keeping it dry because it's non-waterproof. Anything else we want to add? I think we got most of them. The only other thing I can think about is when to come back. So follow-up appointments, making sure we're re-emphasizing that. So parents know when that cast is coming off, when their next appointment's going to be, giving them an idea of that timeline. Great job, guys. Okay, so we're going to go back to our Minty here. Get some things moved back around so I can see. My windows are being rude today. Okay. So next thing we're going to look at is we are going to compare and contrast the pharmacokinetics. So how a medication works with a 6-month-old and a 3-year-old. So both of those patients are going to be receiving acetaminophen, which is everyday Tylenol. So if we are looking at how that medication reacts with them, who is going to absorb that medication faster? That 6-month-old or that 3-year-old?
The 6-month-old?
So actually, the 6-month-old is going to be slower. So because we have an immature GI tract, we have slower gastric emptying. We have a variable pH. So that plus our intestines being smaller, that's going to affect how we absorb the drug. So we don't have as much surface area to be able to absorb there. Our 3-year-old is going to have that established GI system. All of those enzymes are going to be in there for breaking down medications. So they're going to be much more consistent. They also have more intestinal space. So we've got more areas to absorb that medication. So they're going to function a lot closer to an adult than a 6-month-old. So they're going to be more predictable. How is acetaminophen transported through the body? Do we know what its carrier is?
Is it the liver?
That's where it's going to be metabolized, but what moves it through the body? Does it travel in water or fat? Yeah, so it's going to travel in our water. Who's going to have the higher percentage of body water? Our 6-month-old has approximately 70 to 80% body water. So it's going to increase that volume of distribution. So they also have less body fat. So that's going to impact it as well. So we don't have fat blocking our road here. Our toddlers are going to drop their total body water to about 60 to 65%. So we're not moving as quickly through the body here. They also have more fat to get in the way here. So we talked about metabolism a little bit. We said that acetaminophen is metabolized in the liver. So who has closer to adult level liver function?
The 3-year-old.
Yep, our 3-year-old's going to have that mature liver enzyme. So they are going to efficiently metabolize that medication. So knowing that our 6-month-old is going to break down that medication slower, what do we need to look out for?
Liver issues?
Yeah. What happens if we're giving that medication frequently and they're not breaking it down very well?
It could cause a buildup of that medication.
Yeah, we get medication buildup. So we are at high risk for toxic levels of this medication. So because we're not able to break it down, it builds up in our body. So we've got to watch those infants very closely with their medication dosing. So not only do we break it down, but we also have to get rid of it. Where do we excrete acetaminophen?
Our kidneys.
Yep, our kidneys. So urine output is going to be really important here. Who's got the immature kidney function?
The 6-month-old.
Yep, our 6-month-old is still going to be immature. They're not going to filter that medication as well. So again, it stays in their body longer. They don't break it down well. They don't get rid of it well. So we have to watch them for toxicity. Our 3-year-old's going to have that adult level renal function. They're filtering faster, so they're able to get rid of excess acetaminophen much more efficiently. It's got that shorter half-life, more predictable responses. This is why we put so much emphasis on medication dosing and monitoring for our pediatric patients. So if we had medication toxicity, what are some of those common signs that you might see? What tells you a patient?
Like any medication?
Yeah. Yep. What tells you they're having an adverse reaction? Change in consciousness. Yep. What else? Vomiting, changing of any of our vital signs. So their breathing might change, a rash, nausea, dizziness. Yep. Tachycardia. We've got a lot of good ones there. Seizures. Yeah. Hopefully we catch it before then. Any of those GI symptoms, so nausea, vomiting, diarrhea, changes to our vital signs, our assessment. All of those are going to be those good signs of medication toxicity. So things that we're looking out for as we're giving new medications to our patients. So looking at medications again, which are going to be the best locations for injections on our school age and adolescent patients. So there's 2 spots that we like to give injections.
The thigh area.
Yep, so our vastus lateralis is going to be that thigh or our deltoid up in our shoulder. What makes us use that thigh over the shoulder?
The muscles.
Um, what about,
If you do doses,
yeah, our doses? So we're looking at that volume. If it's going to be a large volume, we're going to use that larger muscle so that we're not causing pain or tissue damage. Also, anything that burns or stings when you give it, you're going to want to use a larger muscle group so that you're not causing pain or as much pain and discomfort. Great job, guys. So we're looking at some situations here. So we're getting ready to do a lumbar puncture in a 5-year-old. How are we going to position that patient? What is the best way to position them for that lumbar puncture? Yep, so we either want them to be side lying and we're going to round their back, kind of pull their head and their knees up together, getting them in that nice C-shaped position. Or we can have them sit up at the very edge of the bed and we can just roll their head and shoulders forward. The whole point is normally our vertebrae are stacked directly on top of each other. By rolling them into that C-shaped position, we open those vertebrae up nice and wide so the physician can get that needle in without causing any damage or hitting nerves. So depending on how cooperative your 5-year-old is going to kind of dictate which of those positions that you use. So we can't have them move at all during that procedure. So we want to make sure that we have really good control of them. Here we're getting ready to start an IV in a 7-year-old. So where is going to be the best location for that IV? Why did we choose the forearm and not the hand?
Because they use their hands a lot.
Yeah, they use their hands a lot. So that IV can be kind of interfering in that area. So the forearm is going to be a little bit further back. We don't have to worry about them bending their wrist or getting it caught on something. So that forearm is going to be your best bet there. Scalp IVs are last resort. When they come out, they bleed a lot. And it's very traumatic for parents to see their little baby looking like a unicorn. So we try and avoid scalp IVs as much as possible. Here we are assessing an IV site. And we see that our 4-year-old child has continuous fluids running and we have redness, warmth, and swelling at our IV site. So what does this tell us about our IV? You guys are on it. So this patient has phlebitis. They have inflammation of that vein caused by either irritation from the catheter, the medication, or they might be starting to develop an infection. So we see redness, warmth, and swelling, as well as pain at that IV site. If we had infiltration, that means that medication is leaking out of the vessel. So it's going into the surrounding tissue instead of staying in the vein where it belongs. So that would also present with swelling and tenderness, but it tends to be cool to the touch. You might also see decrease in your IV flow rate. So you might get an occlusion alarm. Where did I go? So here we're getting ready to administer an IV medication. What actions do we want to take before we administer that medication? We are going to do all of these things. We want to make sure that our medication isn't expired. We always want baseline vital signs before we give a medication so that we can assess for reactions. And then we want to make sure that IV is working before we push something through it. So we're going to use that normal saline to make sure our IV is working well. Also, that provides a little buffer zone between anything that we've been infusing and the start of that medication. So we don't have a drug interaction there. Last question here about IVs. So we are assessing a 6-year-old IV site, and we note that it is patent with no redness or swelling, and we've got good blood return. So what are we going to document about our assessment? Yep, we are going to document exactly what we saw. Is this a normal or abnormal assessment?
Normal.
Yep, this is normal. This is within normal limits. IV assessment. This is all the things that we want to see. So we're going to switch gears to another patient scenario here. And we're going to see the Swiss cheese effect happen. And everything about this goes extremely wrong. And we're going to look at that. So we have a busy urban hospital. We are in the pediatric unit. And we have a 5-year-old girl named Chloe that comes in with symptoms of a respiratory infection. The attending orders a blood draw to check for any underlying issues, including a complete blood count and a specific viral panel. So as we're looking at this, we want to look for those process issues because we're going to see something go wrong in every step of the way. And then we want to think about how that impacts the care that Chloe receives. So we get the orders, the nurse is getting ready to do this lab draw. She's pressed for time, so she doesn't explain to the parents or to Chloe what she's doing or the risks. So obviously they are very anxious and confused. So what's the problem with just rushing in and drawing labs without explaining?
It sends you into a panic.
Yeah.
Makes you think there's something more wrong than what you already think is wrong.
Yeah. How do you think Chloe's going to receive you?
Like the enemy.
Yeah. You're just coming in with a needle, going right after her. She's going to be petrified of you. So during that specimen collection, the nurse gets a phone call. She hastily collects the specimen without properly positioning Chloe's arm. So this leads to multiple punctures and a poor quality specimen. So what's wrong with this part of the scenario?
That nurse needs to be fired.
What did we do to Chloe that didn't need to happen?
Stick her more times than needed to be.
Yeah, multiple sticks.
Yep,
Mhm.
We put her second.
You should always be first. What's wrong with that poor quality specimen? What's going to happen as a result?
They won't get proper results.
A
She
redraw.
gotta do it again.
We're not going to get accurate results. We're probably going to have to do it again. Also, we've caused added injury to Chloe because we didn't position her arm correctly. So she's probably going to end up with a big old nasty bruise. She might have some pain as a result of that. Do you think she's going to be very receptive to us redrawing these labs?
No,
Oh, she's not going to let us in the room. Guarantee.
that poor girl.
So not only did we collect a bad specimen, but now we use a temporary sticker to label our specimen. What's wrong with that?
It'll come off.
Yep, it can fall off. What happens if we have an unlabeled specimen?
You have to trash it.
Yeah, lab's not going to run it. So again, we're going to have to restick her. Also, when we transport that specimen, we transport it in a non-insulated container, and there are a ton of temperature fluctuations. So assuming that we had done everything right to this point, what happens if we have a bunch of temperature fluctuations to our sample?
All of it's trash.
Yep. Again, we're going to get inaccurate results because we didn't transport appropriately. So poor lab has been left in the dark the entire time, and they process the sample thinking that all is well and good. And the results come back with abnormal values. So they follow procedure and they call the physician, who is alarmed and immediately calls for further testing. So what happened to Chloe as a result of all of these holes in our process?
Added procedures that would not be needed.
Yep, we're ordering additional testing. What might happen because of faulty results?
She could get medication that she never even needed, and
Yeah.
it can cause more health problems.
Yep. So we've got an inaccurate diagnosis. We might receive treatment that we never needed, or treatment that could be contraindicated in our actual condition.
Because it's not good to give a healthy person medicine that they don't even need whatsoever.
Yes. Yep. What happens to all of the personnel on that floor as a result of a breakdown in our process? What do they have to go through?
Everybody on that floor is considered incompetent.
Yep. So what do we have to do to those staff members?
Write them up.
We have to do re-education, retraining. They're going to have to do extra education here. So we're putting more work on all of the staff on the floor because somebody didn't do the right thing. They didn't follow procedure appropriately. So we're adding stress to Chloe. We're doing additional treatments to her that she doesn't need. And now we've got to identify process issues and retrain all of our staff. So everybody is impacted by one nurse's poor decisions and rushing. So as we're thinking about this, unfortunately, it happens more often than we would like to admit. How do we make sure this doesn't happen? How do we improve this situation?
Delegate. If the nurse is pressed for time, maybe she should delegate some things to other people.
Absolutely. What else?
Because that permanent labels.
Yeah, making sure we're following policy when it comes to labeling.
Don't take a phone call in the room.
Yeah, we don't need to be juggling the phone and trying to draw labs, doing any procedure juggling the phone. If we had absolutely had to take that phone call, what should we have done?
Walked out of the room and excused yourself for a moment.
Yeah, if that lab was time sensitive.
Don't answer it.
Yeah, don't answer the call, or ask somebody else to do it. Say, hey, I've been waiting on this phone call. I have to take this call. Can you draw this lab for me? What if we're not really good at lab draws? What if that's not our strong suit?
Find someone who is.
Yeah, find somebody that is. Should we have just kept sticking Chloe over and over again?
No.
Yep. Especially with our pediatric patients, we do try and protect them as much as possible. So a lot of times there's kind of an unwritten policy that you only stick once, maybe twice, before you have to move on to the next person. So we do try and protect them from repeated sticks over and over again. Definitely making sure that we're taking our time. We have to explain that situation ahead of time. We talked about that. Making sure that we're transporting things correctly, following our policy, taking that extra 2 minutes to gather all of our supplies before we go into the room to make sure that all of our ducks are in a row. Okay, so lots of things went wrong here. Hopefully you don't find yourself in one of those situations. We're going to look at some more procedure situations here. So we are providing teaching to parents of a child with a newly placed G-tube. Which statement indicates a need for further teaching or further understanding? So what tells us that parents don't understand how to care for that G-tube? Looking for the outlier here. Yep, we have to use the ordered type of formula so that we make sure we're getting the appropriate balance of nutrition. Also, we don't want to use something that could potentially clog that G-tube or get stuck in the tubing and cause an obstruction. So making sure that we are following those physician orders. Obviously want to keep the site clean. We want to make sure the tube is in the right place before we start feeding. And typically we don't let parents replace new G-tubes. So once it's been established for a while, if that Mickey button would fall out, we would let them put it back in. But until that G-tube is well established, we like them to come into the hospital to have it replaced, just so it doesn't go in the wrong location. If we are giving patients oxygen via nasal cannula, which finding would indicate the patient is receiving adequate oxygenation? So what tells us that our therapy is effective? Yep, we know our oxygen is working if our oxygen saturations are above normal. In theory, if we are giving oxygen via nasal cannula, that would bring our respiratory rate back down to normal. We should see it in a normal range. Our patient should be breathing comfortably. We shouldn't see any color changes or having to use those extra muscles to breathe. Here we are getting ready to suction a 3-year-old that has a tracheostomy. What is our priority action before we suction? So we know that by suctioning, we are occluding their airway. So we are going to be decreasing their oxygen saturations. So if we give them an oxygen boost before we suction them, then we can help prevent some of those adverse effects from the actual suctioning. And ideally, if we keep their respiratory status stable, then their heart rate will also stay stable during that suctioning event. Okay, our last one, we are performing tracheostomy care for a child. Which intervention is most important to include in the care plan? So this one's tricky. Think about which one, if you left out, would guaranteed cause harm to your patient. If you didn't do this, something bad would happen. So this one is tricky. We all want to do that assessment. We are ingrained to assess things. But even if we didn't do an actual assessment, if we are cleaning that site, we are likely having eyes on it. If we didn't clean that site, we could guarantee that we caused an infection if we didn't do that cleaning action. If we didn't assess that site, we can't guarantee that it would cause any adverse effect. As long as we're keeping that clean, we know that that site is going to be safe. So this one was a tricky one. We have lots of good options, but we're looking for the best option. So when you see that word best or most, you want to think, if I eliminate this, if I don't do this, I can 100% guarantee something bad is going to happen. So we know that we don't necessarily have to suction every 2 hours. We only suction when it's needed or indicated. We change those trach ties routinely because not only are we worried about them being soiled, but we're also worried about them stretching and getting loose over time. So we want to make sure we're keeping them changed regularly so that that trach stays nice and secure. Like I said, if we didn't formally assess that site, it's not going to say 100% that I'm going to end up with an infection or irritation. But if we omit the cleaning process, then that will guarantee us that infection. Do you guys have any questions over anything that we covered today?
I have a question.
Yes.
So when we go to make sure the patency with saline flush,
Yes.
what would be the difference in how much we or how fast we inject the 3 milliliters from an infant to an adult?
Yep. So your IV size is going to kind of dictate how fast that flush can go. Also, with your younger patients, you are not going to be using that full 3 milliliters. Like if you had a NICU baby, you would probably only flush with half to 1 milliliter of fluid. So it's going to be the size of your patient and the size of your IV catheter is going to, I mean, you're going to feel that resistance as you're flushing. Any other questions? That was a good question. I'm going to mute this for a minute. We have just a couple minutes that we can get some Kahoots questions in here. So I will let you log in. 0706. And I will stick it in the chat for us. We might only get to 1 or 2. Okay, we are going to go ahead and start just because we are a little pressed for time. So the best place to administer medication is going to be in that crib. So sitting in your lap, unfortunately, can end up in a bad result for you, and you can end up wearing that medication. Putting them in the crib allows you to have something behind them to stabilize their head if they're gonna be flailing around a little bit. So having them sitting upright in their crib is going to be that best location for you, just in case they are non-compliant and flopping around on you. When we're assessing a pulse on a 12-month-old, we want to make sure that we're listening to that apical pulse. How old do we have to be before we can do a radial pulse?
.5 years old or older.
Yep, 5 and above for that radial pulse. We know that our perfusion isn't super strong before then, so there's potential for us to miss some of those vital signs, those heartbeats might not be transmitted all the way. So our school age kids are in that sexual latency stage of development according to Freud. So he's our psychosexual theorist. So that's where that sexual energy takes a back burner and we are focused on learning and growing our brains. That head down position means we're laying. So we're going to keep them with that head back for 30 seconds to a minute so those nose drops can make it back into those sinuses where they can be effective. Okay, guys, we are going to go ahead and stop our Kahoot there. Looks like Mel's going to be our winner. Let's take a peek at what is coming up. So if you did not submit your week 2 discussion post, you have until Sunday. Double check and make sure that you did your 2 peer responses in case you were one of those early submitters. This week we have our first set of NCLEX questions. So there's been lots of questions on how to set these up correctly. So you have to use this link to Saunders' question in Canvas. So once you click on that, then it will load the link in a new window and it will pop up your setup here. So you're going to ask for an exam. You're going to ask for 50 questions. You are choosing your content area. And for this one, we're looking at developmental stages. The rest of them will be in that pediatric section. But we're going to click the little triangle next to it to drop down the categories. And we have to do all of the different age groups that we've talked about in class. So infant, toddler, preschool, school age, and adolescent. So depending on where you are in your program, you may have done some of these questions already. So this number at the bottom might not be 50. So if that is you and you've chosen everything correctly, but you don't have 50 questions here, you need to make sure that you do step 4. So come over here to the left-hand side, uncheck new only, make sure that box is white, and then reset your used questions. It's going to give you a confirmation. Are you sure you want to do this? Yes, you do. That will guarantee you that you get to those 50 questions. Do we have questions on that process? Okay. There is a screenshot in your week 3 announcement that looks just like this, so you can double check your setup to make sure that you got everything that you were missing. I promised to show you your exam review announcement. So let me find it. Exam 1 review. So this has, as soon as I get everybody's recordings, I will continue to update this with the recordings for you. You have your PowerPoint, and this is the only exam that you will get a worksheet for. Otherwise, you'll use your study guides. You have your dosage calculation resources here. So this one, you have a ton of worksheets that you can do for practice questions. And these are those 2 videos from Professor Bogart. So if you struggle with math, please, please, please watch her videos. She breaks it down into 2 formulas that you need for any math question that you see for the entire term. So she does a fantastic job of explaining math for peds patients. So I highly, highly recommend those. And then you have lots of practice worksheets. For our live exam reviews coming up, we still have a handful. So today is Friday at 1 p.m. Eastern time. Professor Luminoso is doing an exam review today. And then on Sunday, Professor Adair is doing one at 3 p.m. Eastern Standard Time. If you are looking at your course calendar and it does not say what I just said, make sure you check your time zone and make sure that it is set correctly. So our classes default to Pacific Standard Time. So if the times on your calendar look funky, make sure that you are double checking your time zone. That will fix your calendar so that it matches your time. For next week, let's go back to our modules. Next week, we have our first exam together. So please try and log into class like 10 or 15 minutes early so that we can get you checked in. Make sure you have 2 devices ready, one to run your exam, one to run your Zoom so that your camera is on the entire time. Make sure you have all of your chargers ready to go. Everything's plugged in. Also, make sure you have your ID, blank piece of paper or whiteboard for your math questions. We will ask to see your ID. We'll ask to see your entire room before we give you the password for the exam. So make sure you are ready for that. And then we just have our discussion 3 post next week. So we are talking about separation anxiety. So we want to know what those 3 stages of separation anxiety are. And then those interventions that we can do and education to provide to parents to ease these kids through this transition. Be very careful with your resources here. So there's separation anxiety. There's also separation anxiety disorder. And these are 2 different conditions. So with separation anxiety, it starts at 6 months, peaks at 10 months, and continues all the way through our toddler stages. And it happens every single time that our patients are left until they develop those coping mechanisms. So make sure that you're looking at that general separation anxiety. Make sure that you're not getting caught up in that separation anxiety disorder because that's going to lead you astray a little bit. So just be careful with your sources next week. Does anybody have questions about what's coming up, getting ready for the exam reviews?
Yeah, the link to Saunders still is not a link to Saunders for me.
Okay, is anybody else having that link issue? Okay. Sheree, if you can just hang out after class, I want to take a look at it with you.
Okay.
Everybody else have a great weekend, and I will see you all next week. Let me know if you have any issues as you're studying.
Thank you.
I sent you a screenshot of where it takes me. I just sent it over to you.